Hello, this is part 1 of Lecture 5, Electrocardiographic Assessment of Arrhythmia. And our lesson today will be how to interpret an EKG in 4 easy steps. So far we've learned that the EKG waveform is generated by the spread of electrical excitation through the heart. Voltage sensing electrodes on the surface of the chest record the cardiac electrical vector as it shifts in a very predictable way, kind of like a lousy golf swing over the cardiac cycle. And this simple waveform is jam-packed with important information. Remember, there are 3 important components: P wave, QRS complex, and T wave, and there are 3 important intervals: the PR, the QRS, and the QT. Here are today's learning outcomes. Our goal today is to develop a systematic approach to interpret an EKG. And by the end of this session, you should be able to diagnose the common impulse generation or conduction defects that will be illustrated in the practice EKG. There are about 9 EKG disorders illustrated in this practice EKG, and I think that you'll be able to diagnose each one of them without too much difficulty. So, when you inspect an EKG, there are 4 parameters that you should look for. First, rate. Second, regularity. Third, intervals. And 4, the cardiac vector. Let's go through each one of those. One of the first things to consider is rate. And there's a fairly simple way to estimate heart rate on the standard EKG. Recall that the bottom 3 tracings represent a 10-second record. So since this is a 10-second recording, you can simply count the number of QRSs within this recording and then multiply that by 6 to get the beats per 60 seconds or beats per minute. Now this works especially well for irregular rhythms, in which there may be variability over the course of the 10-second recording. So let's take a look at this in lead 2 down here on our 10-second recording. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 QRS complexes, beats. Multiply that by 6 and we get 72 beats per minute. Well, what if you do not have a 10-second recording? There's a very simple way that you can estimate heart rate as well. All you need to remember is that the recording moves across 300 large boxes every minute. So if successive QRS complexes are separated by 1 large box, your patient must have a heart rate of 300 per minute. If the complexes are separated by 2 large boxes, it must be half that rate, or 150 per minute. Complexes every 3rd line would be 300 over 3, or 100 per minute. Every 4th line would be 300 divided by 4, or 75 per minute, and so on. So all you need to do is count off the boxes: 300, 150, 100, 75, 60, and 50. Let's take a look at this recording right here. It's right in the middle of the box, but let's go 300, 150, 100, 75. So we can estimate this patient having a heart rate of approximately 75. The next step is to evaluate the regularity. And the easiest way to do that is to simply visually gauge the uniformity of the spacing between the QRSs. Does this recording look uniform in its rate? No. Notice how the distance between the QRSs varies over the course of the 10-second recording. So, alternatively, we can measure the spaces between the QRS to get a more accurate assessment of regularity. In this portion of the recording, the beats are separated by 5.5 boxes, giving a rate of 55 beats per minute. Here it changes. The interval shortens to 4.3 boxes, and here it's even shorter at 3 boxes. So we can measure the spaces between QRS complexes by either counting the boxes: 300, 150, 100, 75, 60, 50, or we can use a caliper, or simply cut a strip of paper and measure to see if the intervals are the same across the recording. Now, what we are assessing is the regularity. Are the QRSs equidistant over the entire recording? If they are not, we want to know whether they are occasionally irregular. Does the irregularity start in one portion of the recording and then disappear? Or is it regularly irregular? In other words, does it vary in a consistent pattern across the recording? Or is it alternatively irregularly irregular? In other words, randomly changing. Step 3 is to evaluate whether the SA node is pacing the heart. And the easiest way to do this is to assess whether each QRS is uniformly preceded by a P wave. Here, here, here. All throughout the recording, the QRS complex is triggered by a preceding P wave. And if this is the case, then it is quite likely that the SA node is pacing the heart. Another criteria is to assess whether the P wave is upright in leads 1 and 2. Remember that lead 1 has an axis, a horizontal axis, the positive pointed to the left shoulder. Lead 2 is pointed down toward the left hip. So if the impulse originates from the SA node and spreads across the atria, the cardiac electrical vector will be pointed toward the left hip. And that will be in line with both lead 1 and lead 2. So if it is not if the heart rate is not driven by the SA node, for example, it could be an ectopic pacemaker located in the inferior right atrium that has taken control of the heart, then the spread of excitation will be altered. In this case, it will move from the ectopic foci to the left and upward across the atria by myocyte to myocyte conduction. And in this case, the electrical vector of atrial depolarization will be pointed away from lead 2. So in lead 2, we will see a characteristic inverted P wave. The QRS complex succeeds each P wave because the excitation is entering the conduction system at the AV node and is spread throughout the ventricles by the Purkinje network. So if every QRS is uniformly preceded by a P wave, and if that P wave is upright in leads 1 and 2, then almost certainly the sinus node is functioning properly and is controlling the heart rate. Now recall that cardiologists pay special attention to the PR interval, and this is the time required for the impulse to travel from its origin at the SA node across the atria, myocyte to myocyte, or through the internodal conduction pathway, enter the AV node, be delayed, and then spread rapidly through the Purkinje network throughout both right and left ventricles. And recall that the largest part of the PR interval represents the time required to cross the AV node. Remember, AV nodal delay is critical for the proper coordination of the atria and the ventricles. So we can take the PR interval as a reflection of AV conduction. And that AV conduction should take no more than 120 to 200 milliseconds, or in 3 to 5 small boxes. So in this case, 1, 2, 3 boxes, that is within normal parameters. And why is this important? Because the AV node is prone to failure, and it can fail in a variety of ways. Let's take a look at 3 common AV node defects. And this is something that I will expect you to know. Recall that if each and every QRS complex follows a P wave by a fixed normal PR interval, AV conduction must be normal. That is a normal sinus rhythm. However, if QRS complexes always follow P waves, but the PR interval is abnormally long, more than 200 milliseconds or 5 small boxes, then your patient has what's called a first-degree AV block. First-degree AV block. This is generally a minor conduction defect. The atrial impulse is always transmitted to the ventricles, but just with an unusually long delay. And we can see this in well-trained endurance athletes that have what's called hypervagal syndrome. Their heart ejects more blood on each beat, so fewer beats per minute are required to sustain the blood pressure and satisfy the baroreceptors. So as an adaptive response, the sympathetic nervous system is toned down and the vagal parasympathetic system is upregulated. And that vagal drive to the SA node slows down nodal firing, heart rate, and vagal input into the AV node slows down AV node conduction and therefore creates a long PR interval. So in this case, we count up the small boxes and it's 1, 2, 3, 4, 5, 6, 7 or 8. So about 260 milliseconds is abnormally long. It's taking the impulse to travel from the SA node across the AV node and into the ventricular conduction system with an abnormally long delay. So this is first degree AV block. Well, how about second degree AV block? That occurs when the atrial impulse is transmitted to the ventricles only sporadically. So occasionally, for example right here, a P wave fails to trigger a QRS complex. There should be a QRS complex here, but that atrial excitation did not traverse the AV node to excite the ventricle. And that sudden drop beat will result in a prolonged filling, which will cause a palpitation on the next beat. So we see second degree block when there is a sudden dropped QRS without PR lengthening. And this can occur when there is a conduction impairment in a variety of different locations along the AV node or the ventricular conduction system. Third degree block is when AV node conduction fails completely. There is no longer any relationship between P waves and QRS complexes, as you see in this tracing. There is no communication between the atria and the ventricles anymore. And note that the P waves are occurring at about a rate of 70 per minute, so 300, 150, 100, 75, about 70 per minute, and they're occurring regularly at that rate. However, the QRS, the ventricular depolarization, is occurring at a much slower rate with no relationship between atrial depolarization and ventricular depolarization. Now, why would the ventricular rate be much slower than the atrial rate? Look how the ventricular rate is about, let's count it, 300, 150, 100, 75, 60, maybe 55 or 60. And the QRS complex is normal and narrow in width. So this must mean that the excitation is is entering the ventricles through the conduction system. However, the pacemaker of the ventricles is now dissociated from the SA node and now is another pacemaker, firing more slowly, has taken over control of the ventricles at a slower rate. So here we have a typical standard EKG, and we can measure the PR interval. Let's go to lead 2, and we'll measure 1, 2, 3, about 3.5, 4. So the PR interval is about 150 to 200 milliseconds. And if we're lazy, we can consult the EKG machine's built-in microprocessor, which analyzes the waveform of every beat in the recording, and it will tell us that the PR interval in this case averages 164 milliseconds. Yes, this is below the normal parameter of less than 200 milliseconds or 5 small boxes. So this patient is normal PR interval. Keep in mind that if the heart is healthy and being paced by the SA node, the P waves will be upright in leads 1 and 2 because atrial depolarization will proceed from the SA node pointed down toward the left hip. So if the P waves in lead 1 and lead 2 are upright, then we can be pretty sure that the SA node is pacing the heart normally. Moving on, the next step is to evaluate the duration and size of the QRS complex. What occurs between Q and S? Remember, that's ventricular depolarization. So the width of the QRS complex reflects the speed of ventricular excitation. And for a narrow QRS to be produced, excitation must be distributed through the ventricles rapidly. And this can only occur if the impulse is distributed properly by the Purkinje conduction system. In other words, the ventricular wiring system. Ventricular myocyte to myocyte conduction would just be too slow, and in that case, the width of the QRS would become abnormally wide. So if you see a normally narrow QRS complex, the ventricles must have been excited by the ventricular conduction system, and that impulse must have arisen above the AV node or within the AV node itself. So the normal width of the QRS is 1 to 3 small boxes, or 40 to 120 milliseconds. So an impairment in one of the septal bundle branches, for example, would cause a widening of the QRS complex. How about the amplitude of the QRS, the height of the QRS complex? That will reflect the mass of ventricular muscle. Normally, the precordial lead V6 is used to assess the amplitude of the QRS, and it should be a little more than 2 large boxes. In ventricular hypertrophy, this can be increased dramatically. So how come? You're all aware that if you subject a muscle recurrently to an afterload stress, an afterload resistance, that muscle will hypertrophy over time. Just like a weightlifter repetitively lifting weights imposing an afterload stress on their arm muscle, those muscles, the skeletal muscle in the arms, will hypertrophy. They will grow longer and thicker with contractile elements. Well, the heart is the same way. If we subject the left ventricle to an afterload stress, a resistance to ejection, for example, in hypertension, that ventricle will hypertrophy. Suppose we have a blood pressure in excess of 130 millimeters mercury systolic. In that case, the left ventricle must eject the blood against a high resistance. In order to eject the blood into the aorta, the ventricle must develop extra pressure in order to push the blood onto the systemic circulation. So we have introduced a recurrent afterload stress on the left ventricle, and over time, that muscle, the left ventricle, will hypertrophy. That's a compensatory response, and as we get further along in Block 2, we'll learn about the law of Laplace and circumferential tension and how to mitigate that. So ventricular hypertrophy, in this case it would be a concentric hypertrophy induced by chronic hypertension, in other words, a pressure overload. There are different types of hypertrophy, for example, eccentric hypertrophy, that is seen in different pathologies versus pressure versus volume overload. We'll talk about that later on in the block. Well, another consequence of this increase in muscle mass on the left side of the heart is a shift in the cardiac vector and what we call a left axis deviation, and we'll talk about that next. We'll also have a larger QRS magnitude seen in V6 most prominently, reflecting the fact that there is more muscle mass contributing to the depolarizing current, more voltage reaching the surface electrodes, larger QRS magnitude in a hypertrophied heart. So all of you will be coming in and getting recordings of your EKG in small groups. And part of that exercise will be to measure your heart's electrical axis. It's really quite easy. The electrical axis of the heart is simply a snapshot of the cardiac vector at the instant of ventricular contraction. In other words, during the QRS complex. And this plot here is called the radial coordinate diagram, and it is used to graphically determine the cardiac vector. It shows the lead axis for all 6 limb leads. If you measure hundreds of healthy people, you'll find that the normal electrical axis of the QRS ranges between -30 and +105. To calculate the axis, just examine the QRS complexes from any 2 EKG limb leads. So let's take a look at this example here. Here leads 1 and 3 are used to calculate the axis. You just sum up the height of the QRS spike in millimeters. In this case, it is 16 small boxes above the isoelectric. And if you have a negative deflection in the QRS complex, you must subtract that value from the height of the QRS. So in this case, we have a Q wave that is -2.5, in other words, below isoelectric. So we have to subtract that from 16 to get a sum of +13.5. Then you locate lead 1 on the radial coordinate diagram. It's here, 0 degrees. And you draw a perpendicular line extending from that point on the axis. Here's 13.5. We come over to 13.5. We draw a perpendicular line from lead 1. And then we do the same for lead 3. In this lead 3 recording, the height of the QRS above isoelectric is 14, in other words, the R wave, and the negative deflection is -5, the S wave. We sum those together to get +5. We come over to lead 3. We come down to +9, and we draw a perpendicular from that point. The point at which these 2 lines intersect gives us the axis in degrees. And this person's axis is 53 degrees. That is well within normal. But suppose disease causes a ventricle, either the right or the left, become enlarged, or a conduction defect distributes the excitation in the wrong direction and rate. The axis will shift in the direction of the hypertrophy. Left axis deviation can occur in hypertension, as we've just seen. Hypertension is an afterload stress on the left ventricle. That side of the heart will hypertrophy, and the increase in muscle mass will cause a leftward shift in the QRS vector. We can also see this in aortic stenosis. This is where the aorta does not open fully, possibly because it becomes calcified. And now the the left ventricle must push the blood out across a greater resistance into the aorta. And every time it beats, it's subjected to an afterload stress, just like in hypertension, and it will hypertrophy on the left side. Congestive heart failure, we can also see a left axis deviation for a slightly different reason, which we'll talk about later in the course. We can also see a left axis deviation in conditions where the heart's position is altered. For example, in pregnancy, as the developing fetus grows, the diaphragm is pushed up and the heart is shifted more toward the left. This can also occur in extreme obesity. How about a right axis deviation, where the cardiac vector in the QRS is now shifted beyond 105 degrees into this quadrant down here? Right axis deviation can occur in pulmonary hypertension. Why? Because if the right ventricle, which is not really accustomed to ejecting against an afterload resistance, if that is subjected to pulmonary hypertension in the pulmonary artery, then the right ventricle will hypertrophy, and that enlarged greater muscle mass on the right side will shift the QRS vector toward the right. We can also see this in chronic obstructive pulmonary disease, where the global hypoxia throughout the lung due to poor ventilation will cause a vascular constriction of the pulmonary arterioles, and that will induce pulmonary hypertension. We'll talk about that later on in the block. So here we have the standard EKG, and the question is the electrical axis normal in this individual? Well, we could take any two of the limb leads and do the radio coordinate diagram exercise, or we could rely on the microprocessor of the EKG machine and look at this middle position. In other words, the R axis, part of the QRS complex, is recorded here on the readout. So in this person, the electrical axis is 57 degrees, which is well within the normal axis. In other words, pointing toward the left hip. So that concludes part 1 of lecture 5. Take a little break, come on back, and we'll have a short wrap up on EKGs, and we'll go through a few examples.